Okay, good morning, everybody, and welcome to our webinar on long COVID in partnership with St George Hospital. My name is Bertha Harvey, and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people across the land which we work. I recognise the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us today. So let's get started and welcome Dr. John Estell, who's a staff specialist in rehab medicine and director of rehabilitation medicine at St George Hospital. With us today also we have Kylie Turner, who is a chronic kidney disease CNC at St George Hospital, and Dr. Martina Gleeson, who will be doing a health pathways demonstration following the presentation. So welcome, Dr. John Estell.
What I will talk about this morning is what's happening in the long COVID space. I think we're all very familiar with what's happening in the acute COVID, and it continues to change on a weekly basis, depending upon the whims of the federal and state health ministers. But today I'll talk about some of the work coming out of the Agency for Clinical Innovation and how we deal with patients who have some of what we're now calling the post-acute sequelae of COVID-19. Colloquially, everybody knows it as long COVID. So post-acute sequelae of COVID-19 is a syndrome, and it's been defined by the World Health Organization as the condition that occurs in individuals with a history of proven or probable SARS-CoV-2 infection. It is usually 3 months from the onset of the initial COVID illness, and symptoms can fluctuate or relapse over time. But it also has to include the fact that symptoms must have been there for at least 2 months and cannot be explained by an alternative diagnosis. So it's proof is one of the challenges, and I think that's one of the difficulties in actually diagnosing somebody with long COVID. The World Health Organization states that common symptoms include fatigue, shortness of breath, cognitive dysfunction, but there are also others, and that these symptoms must have an impact on everyday functioning. In terms of sort of the breadth of the symptoms that people experience, it's really significant physical, psychological, and cognitive impairments. And these can persist despite the clinical resolution of the infection. And one of the challenges is trying to work out exactly what's the causation methodology for long COVID. So why do some people get it? Why does it persist quite severely in some people? And in others, they do get a progressive resolution over time. And although we're studying it, we still haven't quite worked out why. If we look at historically what's happened, and I'll be using a lot of work from both the United Kingdom and the United States, evidence that suggests that somewhere between 10 and 20% of people experience a variety of mid-term and long-term effects after they recover from their acute COVID infection. This is historically applied to the alpha, beta, and delta strains. We sort of had our anniversary of Delta last month in Australia. Each of these strains produced quite a severe initial inflammatory condition, and quite a significant proportion of people do go on to experience long-term symptoms. In terms of the Omicron variant, we've really only had about 8 months worth of experience with Omicron. So we haven't got huge experience and evidence on what percentage of people go on to develop the long-term symptomatology. Actually, I might just go back one. From my experience, what we've seen in Omicron is because some of our cohort have been vaccinated, we know that vaccinations reduce the severity and also the number of long-term symptoms. And because the Omicron variant itself seems to, in the majority of people, have a milder clinical course, we're not seeing as much in the way of long-term symptomatology. So just running through some of the common symptoms, I've highlighted the most significant ones in bold type, but definitely in the respiratory system, cough and breathlessness are particularly problematic. What we know in sort of athletes who've had COVID, they can lose up to 20% of their lung function with a severe case of COVID. And obviously, if you're an elite athlete, relying on, you know, your physical fitness and your exercise conditioning to compete at your sport, that can make a huge difference to those individuals. Cardiovascular disease, we are seeing persisting chest tightness, chest pain. We do see patients who develop palpitations. Some of the orthostatic problems, so postural hypotension or the POTS syndrome. Our cardiologists are reporting cases of those, and we do have a number of them who've been admitted through St George Hospital. I suppose the most common ones are those more general conditions, and particularly fatigue, and I'll talk a little bit about fatigue as I sort of talk through some of the treatments and how they work. But fatigue's probably the main persisting symptom after COVID. We also see some patients with persisting fevers and with generalised, you know, body muscle aches and pains. Probably in the top 5 is the cognitive impairment or the brain fog that people with COVID talk about. But there are other neurological symptomatology. So we've seen patients with autonomic dysfunction, particularly amongst the elderly. We see a lot of delirium, and that can persist for quite long periods of time. Dizziness, headache, some people with some balance disturbance, peripheral neuropathies, sleep disturbance and visual disturbance. Interestingly, I've also had a number of patients who've had some of these symptoms after immunisation, and we've seen that with all 3 brands of the vaccines that are available. Probably slightly less commonly, people with gastrointestinal problems, and it's hard to attribute them directly to COVID, but certainly we do see patients with change in bowel habit, diarrhoea, nausea, vomiting, and some with abdominal pain. Not moving on. There we go. In the musculoskeletal system, again, those muscle aches and pains, joint aches and pains, particularly if people have pre-existing conditions, that seems to worsen their arthritic pains, and their pain seems to last much longer. The others, sort of ear, nose and throat, there are reports of people with different earaches. Definitely loss of taste and smell was a particular early sign, and in some patients that does persist. The majority of people seem to recover their sense of taste and smell, usually within the first month after their infection, but there are some who do persist much longer. Dermatologically, skin rashes are a particular issue. Sometimes that's got to do with the COVID disease. Sometimes it's got to do with medications and interactions that occur with what patients are taking. Some of them will be prescribed, some of them will be found on the internet. And sometimes it's quite difficult to work out what's actually causing the skin rashes, because people tend to take lots of things that others recommend to try and help their post-COVID symptomatology. I think one of the big things that we're seeing in combination with the fatigue and the respiratory limitations is a lot of psychological symptoms. And if I think back to the Delta wave and what was happening with lockdowns, with separation of families, with no major life events, a lot of people ended up with psychological trauma as a result of that. I think the other thing that went unrecognised is that sometimes the disease was passed within families, so it might have crossed the generations between grandparents, parents, children. And in some occasions, it was as the older patients who actually succumbed to COVID and passed away. And that disrupted the whole family care system that a lot of the multi-generational families had. So that it may have been that, the parents were working and the grandparents were looking after the children. Sometimes, as a long day care, sometimes before and after school care. And the loss of the grandparent or grandparents really disrupted the care systems within families. And there was a lot of anxiety and a lot of distress and grief as a consequence of that. And I think a lot of that has not been well resolved. And I think there's a persisting cohort in the community that still have a lot of psychological symptoms because they weren't able to, the loss of loved ones was sudden. They weren't able to visit them in hospitals. They weren't able to say goodbye. They may not have been able to have a funeral. And so I think there's a lot of unresolved grief in the community around this, which is persisting into some of the other symptoms. In talking about long COVID, I think particularly amongst the alpha, beta and delta strains, what we see is that COVID has a very prolonged fatigue. And it's that prolonged fatigue mechanism that I think leads on to the development of the long COVID. The interesting thing for us is that that fatigue doesn't respond to what I'll call traditional rehab therapy, which is sort of a progressive increase in the load, the distance, the effort, that people are putting in. So after, say, a knee replacement, what you're aiming to do is get the range, the strength, and the endurance back in the musculature. But in COVID, it didn't really work that way. So as we tried to upgrade people's exercise programs, in fact, they decompensated and they couldn't progress in their recovery. And it was a really prolonged recovery. And I suppose I would tend to liken it to some of those sort of persisting fatigue syndromes that we see in the old, infectious mononucleosis type conditions where for some people, and it's not everybody, but obviously for some people, they had a really prolonged and persisting fatigue that, in some cases took, months to years to completely resolve. And I think we're seeing some of that style in the recovery from COVID. The challenge is, what's the mechanism that is causing all of these different symptoms, and is it possible to link it, all together somehow? What we know is that COVID actually results in a very hypercoagulable state. And in the early disease, autopsies revealed multiple microvascular clots and occlusions of, small blood vessels, particularly in the lungs, but also elsewhere in the body as well. And so, the suspicion is that it's these sort of microvascular events, and depending upon which end organ they're affecting, it's probably that process that's initiating some of the prolonged symptomatology in COVID. So obviously, if you're getting microvascular events in the lungs, which is extremely common, you'll get breathlessness, you'll get restricted airway capacity, you'll get difficulty in increasing exercise. If it's affecting the heart, then obviously that's where we're getting some of those cardiac issues. Obviously, brain will affect more of the neurological, but also some of the psychological effects of the disease. The challenge is, how do we actually start to progress people in their recovery, but also facilitate them getting back to, their normal work, those sorts of things. I did say vaccination does seem to have an effect in reducing the progression of COVID onto long COVID. So in the United Kingdom, looking at 1.2 million adults, they found that the odds of having persisting COVID symptoms 28 days or more after the infection was diagnosed was halved if people had had 2 vaccine doses compared to no vaccination at all. And then in the US, a similar study reports that at least 1 vaccine dose reduced your risk of symptoms, by about 10 to 20%, to about 10 or 20%. So we certainly know that as the Australian population began to be vaccinated about 12 months ago, the presentations of patients with long COVID has probably declined. And certainly the Omicron variant plus vaccination, I think we're seeing a much smaller percentage of patients progress on to long COVID. The difficulty is, because the Omicron variant has infected, 25 times more of the population, there's probably still roughly the same absolute number of patients with prolonged COVID symptoms with the Omicron variant as there was with the Delta variant, even though the rates of infection were much smaller. Some of the things to think about is, and it came up in the WHO definition, that we need to make sure that we're not attributing symptoms to long COVID when they're really another cause. So there's no reason why somebody can't have a myocardial infarct, a month or 2 after they've had COVID. Okay, patients may have had a myocardial infarct at any point in time. So the big thing is really to be aware of the red flags and make sure that where there are red flags, that we don't just attribute them to prolonged COVID symptomatology, but really exclude a new cause for them. So anyone with focal neurological symptoms or signs, obviously that's a risk of a stroke. New confusion, palpitations, arrhythmias, chest pains, all need to have cardiac causes excluded. Any change in severity or new onset or worsening breathlessness, even if people are in the recovery phase after COVID, we still need to exclude other causes such as secondary pneumonias or lung infarcts or those sorts of things. Syncope and chest pain, I think, are pretty obvious. But it's really trying to not subconsciously attribute everything to the post-COVID symptomatology cluster. And this is basically how I think we should devise the treatment strategy for COVID. So 90% of our iceberg sits under the water. And my feeling is that the majority of people with post-COVID symptomatology now are going to have single or a number of minor persisting symptoms, which can be managed by, their general practice or their specialist outpatient service. And it's only that group that sits above the water that I think will probably progress on to requiring a pulmonary rehab program, particularly where persisting shortness of breath or breathlessness is the main symptom, or more generalised rehab, particularly where they've got some of the physical and psychological symptomatology. So I think, this cohort down here will be the general practice, and the bit that's making all the noise and pointing up here is where the hospital system will assist you guys to manage the patients. And so in terms of sort of clustering, I feel that probably the majority will be in primary care. The next biggest group will require pulmonary rehab programs. Then those who require more generalised rehab because of their multiple needs, whether that's allied health or medical or whatever. And then there'll be some that'll be just single specialist groups, particularly the neurologists, the cardiologists will see a number of patients in those groups. And sort of just as a rough percentage, I think, we'll probably end up with 3/4 being, principally managed in primary care. About 20% will go through pulmonary rehab programs, and then, just a small handful in the more multidisciplinary or highly specialised groups. And there'll obviously be differences to that. So a lot of the renal patients, because they're in regular contact with the hospital, the renal physicians will probably, assist in the management of that patient group much more so. So what is our district doing for long COVID? There's a number of long COVID clinics have been set up in multiple health districts. St Vincent's has a clinic at the moment that is receiving approximately 100 referrals every week, and they have somewhere between 8 and 10 appointments to see patients each week, and they are getting referrals from their local area, every local health district in New South Wales, and from people in interstate. The challenge for them is actually dealing with the huge demand that's being generated through the social media, because they're finding that they're getting a lot of people with really quite prolonged symptomatology, some of which goes back decades and obviously predates COVID as the precipitating cause. So actually being able to narrow the cohort that they're seeing down to those with the post-acute sequelae of COVID has been the real challenge. In southeastern Sydney, we've been agitating for a long COVID service for approximately 8 months. The district is now in a consultation phase with the major facilities and medical specialties that will be involved in providing this service, and working through the development of the model of care that they want to implement, in that it will be a South East Sydney district-wide service, but there will be elements that will be delivered on multiple sites. And obviously, there will be the capacity to do it in a hybrid way. So it may be that some things need to be done face-to-face. So particularly if patients or people are needing respiratory testing, that will need to be done face-to-face. But a lot of it can probably be done as we are this morning on telehealth.
It's just a question in the Q&A, Dr. Estell. Is there a role for anticoagulation as prophylaxis against the microvascular thrombosis caused by COVID, e.g. aspirin, etc.?
Yeah, that's a question that's been tossed around for probably 18 months. There probably is a role in the early stage of infection. So that probably, when you start your antivirals, you should probably also commence aspirin. Now, obviously, that will depend on, the age, the comorbidities, and things, but you probably don't lose anything by using something like aspirin in that early phase. Does it prevent the development of the microvascular complications? We don't know. No one's done a randomized controlled study. But in terms of the logic behind it, it probably does make sense in combination with, particularly now that, antivirals are available on prescription. I don't know where you source them from, but you can write the prescription to treat anyone who's been diagnosed with acute COVID infection. So my answer is probably yes. So yeah, this is what sort of southeastern Sydney is doing at the moment. I'm hopeful that we'll have something up and running over the next couple of months. But that will probably be about 12 months late, because we probably really needed long COVID clinics after the big Delta sort of hospitalisation wave, when people were not fully vaccinated and in fact were struggling to access vaccination. And the death rate amongst people infected was still quite high as a percentage. But at least we might get to something. And if St Vincent's is getting 100 referrals a day, then I think we will probably get, hopefully not that many, but a similar magnitude. It may be that some of the referrals that are currently going to St Vincent's would come to the South East Sydney Health District instead. The main sort of methodology by which we work out who needs what services is the Yorkshire Rehabilitation Screen. So this can be self-administered, and it's really just trying to stratify what symptomatology people have and how severely is it affecting them. There's about 15 questions. Obviously, the first question is, have you had COVID-19? Because there's quite a cluster of patients who refer themselves to these services who haven't, but have you had COVID-19? And then it works through, breathlessness, cough, swallowing or nutrition problems, and you rank yourself pre-infection and also how you are currently. And then obviously the discrepancy between, the pre-infection and the current scoring determines how people are stratified to what services. But there are things, fatigue, continence, any generalised pain and discomfort. Have they had, brain fog, cognition issues, anxiety, depression, PTSD, so that sort of psychological domain. Have they had any problems with their communication, mobility, personal care? Any other activities of daily living, such as, work, study, shopping, and their social role. And then just trying to get an idea of how people have been affected. And then they just sort of generally ask about some other more generalised symptoms, such as palpitations, dizziness, generalised weakness, sleep, or persisting fevers. And then for some reason, they put the last question around the other way, so that people who are, used to scoring in one way for the 15 questions above now suddenly have to flip the way they answer the last question. But just as a comparator, how would you rate your health pre-COVID and how would you rate it now? And obviously looking at that change. And this is the sort of the only validated tool that has sort of developed so far. There are others that are working through the validation process, but the English had quite a few problems with COVID. They had a lot of long COVID, and so this tool was developed and it's been incorporated into the ACI's post-acute sequelae and symptomatology for COVID. So that's a quick run through. I saw there was a question. The challenge is that the vaccination is quite good. It's the antiviral treatment that is really becoming problematic. So sotrovimab, which we were using in January to March, really is not effective against BA2 or anything more recent than that. So it did work against Delta quite well. It did work against BA1, but now BA2, 4 and 5, sotrovimab doesn't work at all. So we are not using sotrovimab in the system at all now. So we're using molnupiravir and paxlovid.
There is a question there. Is there any rehab that might help the cognitive impairment?
Yes, there is. The challenge really is not to cognitively overload and try and often patients themselves try and get back to work / study / normal. It's really a matter of sort of pacing, and a bit like the physical side of things, it takes time. There are, particularly the occupational therapists, have programs and training programs that they're working through with people. Often they can be self-paced, but the idea is not to cognitively overload people, but just try and gently pace them much more slowly than you would, say, a stroke or something like that, where you can really challenge people to try and improve their cognition in the early stages. Yeah, it just seems to be just the whole time course is quite different.
There's another one there. Could you comment on great similarities between CSF/me and long COVID and the implications for management?
Yeah. I think long COVID, particularly in that Delta cohort, is very similar to ME. So myalgic encephalitis. The cognition, the fatigue, and the prolonged nature of the symptoms are really quite similar. I think, as I say, we've got working hypotheses on why we're starting to see this in the post-COVID brain, but we haven't got, definite evidence or proof of why it works that way. But symptomatically and symptomatologically, they are very similar.
I had only prepared one slide, but I can also show people some of the health pathways that are relevant to this. So we'll start with, can you touch on how to refer to the various services and the role of allied health professionals? So I'm going to step back, John, and let you do that one before I...
Yeah, I'm hoping once we've got a district-wide service that we will be publicising the referral pathways into that. The challenge at the moment is probably whatever is the most problematic symptom, probably refer in for that specialty. So, for instance, if it was breathlessness and respiratory, refer there. The challenge is that the public hospital outpatient system at the moment is quite overloaded. We've got a huge backlog of chronic conditions that we haven't been managing over the last 2 years. So we're sort of in some catch up with, the medical management of some of our chronic patients, as well as trying to deal with the new cohort. Allied health professionals, particularly in the therapeutic sense, will be critical to this. So if you've got patients with, I'll call it, cognitive distress, the psychological symptomatology, if you can access a mental health plan and find a clinical psychologist with a vacancy that they can see someone in under 12 months, I would recommend you see them there, because the hospital system doesn't have them. So that is going to be the challenge, is being able to get the right patients in to see the right people in a timely fashion. I'm hoping once we've actually got a pathway that with publication, it'll make it much easier for you, but I'm not in control of that element.
Can I also add, John, that there is a post-COVID specialised assessment health pathway, and it links all of the local services for things like pulmonary rehabilitation and all of the single organ specialists that might be relevant to your patient's presentation. And so all on one page, you've got links to cardiology, pulmonary rehab, multidisciplinary rehab, and ENT, or like you name the specialist, it's linked on that page and will take you to the part on health pathways that will help you identify those services. So for people who are not familiar with health pathways, you might find that a good place to start.
I've got one more question. Comment on the amount of deconditioning that occurs after getting COVID. With shortness of breath on exertion relative to deconditioning, should rehab be gradual or is tolerated? It really depends on what organ systems are affected by the COVID disease. As I say, I'm seeing less of it with the first couple of Omicron variants. But what anecdotally, the patient groups that I've looked after, some of the competitive or recreational sports people, they're saying that, they will lose, the top 20% of their exercise capacity. So say your weekend cyclists who, will ride, down into the national park and out again, they're saying that, they can make it to waterfall, but they can't go up and down the hill at that waterfall because they just do not have the exercise capacity to get back up that hill. And that persists for, a month or two after an infection. The relative to deconditioning, let's say, it's probably similar but slower in terms of building up somebody's capacity if they're deconditioned from a different medical illness. Say an acute abdomen where they were in hospital, bedridden for, a week or two, and then sort of reconditioning them, getting them back to their physical fitness. I think COVID seems to or the respiratory side of their deconditioning seems to last much longer. So it's a slower recovery than your standard deconditioning.
One slide for everybody, and that's just to let you know which of our health pathways are relevant to today's talk. There's a QR code on the left-hand side for you if you've never used health pathways before, with the login, username and password to help you access. And if you are working on the border of the Sydney Local Health District and the Southeast Sydney Local Health District, that same username and password can be used to access the Sydney Health Pathways as well. We do have a pathway on long COVID. It's currently called post-COVID-19 conditions, and it aligns quite well with the ACI guideline on management of post-COVID conditions, because they actually used some of the work we had done to inform some of what they were, what went into their guideline. And there's also the post-COVID-19 specialised assessment, which is actually, like in health pathways parlance, assessment is actually your referral page, so that you'll find the links to all of the relevant clinics on that pathway. There's also a pathway called multidisciplinary rehab assessment, which will help you identify the limited but available rehab clinics available in our area. The COVID-19 active case management is the big pathway that is to help you manage your patients who have COVID. And right up the very top of that pathway is the quick reference guide to the COVID specialised treatments and the antivirals, and the PBS update that happened over the weekend. Thanks, Mark Butler, for the heads up in advance. But we have actually updated that pathway overnight, and it now shows the current PBS indications for the COVID antivirals. And I've put in the streamline codes, and I'll just give you a warning that the streamline codes at the moment are the same as what they were on Friday, with the extended indications, but they are going to change on August the 1st. So if your clinical software isn't updated on August the 1st, you might have outdated streamline codes, but I'll make sure that the new streamline codes are actually on the pathway on August the 1st when they change. So hopefully that will help you. We've also, I just wanted to mention also that we have a pathway called mental practitioner wellbeing. I think it's safe to say that it's been a particularly challenging time for our own wellbeing. And so, sorry, I've somehow closed that page. Oh goodness, sorry. And it's important, I think, for us to be aware of our own well-being and aware of the well-being of our colleagues, because everybody in the whole health system is stressed. And so looking after your own well-being so that you can access your own compassion for your colleagues and being aware of their needs as well as your own, I think is really important at the moment, as we're all at somewhere along the burnout phase. And there's also a lot of respiratory pathways and cardiology pathways, which you'll be able to find on the Health Pathway site. I don't think I'm going to give you a live demonstration today because I think it's probably better that you go and have a look at the pathways yourself. And hopefully just giving you that list of pathways that might be relevant to what you're doing at the moment will be helpful. I'm happy to take any questions or leave the floor for John to answer any further questions that might come up.
I want to thank our speakers today, Dr. John Estell, Dr. Martina Gleeson, and Kylie Turner for helping out with the questions. So thank you again, everybody, for joining us today. Thank you to our speakers and enjoy the rest of your day.